Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I am joined by Dr. Dania Tamimi. Dr. Tamimi received her DMD and Certificate of Fellowship in Oral and Maxillofacial Radiology at Harvard School of Dental Medicine. She is a diplomat of the American Board of Oral and Maxillofacial Radiology and is an honorary fellow of the Royal College of Physicians and Surgeons in Glasgow. Dr. Tamimi is a reviewer for numerous publications in the dental and medical arena, as well as the lead author on two textbooks, Specialty Imaging Dental Implants and Specialty Imaging Temporomandibular Joint and Sleep Disordered Breathing, and a co-lead author on Diagnostic Imaging Oral and Maxillofacial. She also lectures nationally and internationally. Dr. Tamimi's diverse background includes being a fitness instructor, a Pilates instructor, and a trauma-informed yoga instructor with training in yoga for PTSD and chronic pain and disease. With this holistic knowledge, she brings together a comprehensive view of the human body into her radiographic interpretation and her teaching, and that's going to become abundantly clear as we go through today's episode. She currently runs her oral and maxillofacial radiology practice in Orlando, Florida. During today's show, she and I are going to discuss how to communicate with patients and parents regarding why radiographs are needed, what types of radiographs should be taken, the facts about CBCT imaging and its clinical indications, whether or not dentists should read their own CBCT images, the reasons why many orthodontists are resistant to incorporate 3D imaging into their practice, the importance of detecting chronic mouth breathing, the reasons why, as a profession, dentistry needs to focus more on diagnosis and holistic patient care, and much, much more. Also, if you're interested in learning how to implement early airway-focused interceptive orthodontic and dentofacial orthopedic treatment into your practice, be sure to check out the 2-day in-person course I'm running this November 13th and 14th in Fort Lauderdale, Florida with my friend and colleague, Dr. Daniel Camacho. It is going to be an amazing event that we have put together, and it includes 41 hours of ADA CERP recognized CE, comprehensive treatment planning guidance and instruction, and observation of live patient care. We're limiting it to 20 attendees because we want it to be an intimate and personal experience for everyone in attendance. And be sure to use code EARLYBIRD1000, that's EARLYBIRD1000, to get $1,000 off your registration fee if you enroll before the end of May. I promise this course will transform how you approach early airway-focused treatment and allow you to change more lives than you ever imagined possible. So without further ado, let's get on to today's episode with Dr. Dania Tamimi. Enjoy the show, everybody. Welcome to the Doc Podcast, Dania.
Hi, how are you?
I'm great, thank you. So nice to have you on. Thank you for joining me. We were just talking before we hopped on that we're not that far away geographically. You're kind of center Florida, I'm Southwest Florida, and just talking FSU versus UF and the Florida dynamics.
Yeah, all
that
that
people,
good stuff.
the Floridians will know about. But you have a really cool story of your life, and you've done a lot, as many of the listeners know, but some may not. We have a lot of laypersons who listen to the show as well and may not be familiar with you and your work. So if you don't mind, just take a few minutes and go into how you got to be the Dr. Dania that you are today.
Okay, well, I am an oral and maxillofacial radiologist. Let's start there. So what that means is I'm a dentist first and then a radiologist. I specialized in radiology. I did my training at Harvard School of Dental Medicine. And after that was done, I went into private practice. And I've been in private practice ever since. So I currently work from home. And actually, I've always worked from home. So that was always interesting, raising kids and being in the midst of all the, trying to balance the professional and the personal stuff. Because there's no clock in, clock out, like people who actually have a job, in a clinic or an office kind of thing. So, but my heart's always been in academia. I've always loved teaching. Ever since I was a kid, I was always teaching something, either a student of something or teaching something, whether it's aerobics, or ballet or whatever it is, I've always tried to convey what I have to others. And so I found a venue, a way of practicing what I do also through teaching. And I do this quite often. I give private sessions to dentists who want to learn how to read their imaging, as well as at conferences and stuff like that. So I have a combination of a desk job and a really cool travel job too. So what else do you want to know? I've had a career in fitness as well as a career in dentistry. Yeah. So I had a parallel career actually through dental school and through my radiology training.
Really? And what type of fitness?
Well, I started off with spinning. And then I went on to yoga and then Pilates, and for the longest time, I had both those worlds running concomitantly. And then the kids came along and something had to give, right? So going from like 10 classes a week and everything radiology to one class a week, in addition. Yeah. And then slowly that tapered off. And the thing that I've always wanted to try to bring the two worlds together, and it didn't come together until my mentor, David Hatcher out in Sacramento, and he's an amazing radiologist, and he really opened up my mind to just the connectedness of the TMJ to the airway to the dentition, because in radiology training, they teach us how to look for pathology, and they teach us how to look for specific conditions, dental or otherwise. But trying to put it together and making it clinically relevant, that link really came from him. And then came the understanding that it's all connected, like the head and the rest of the body is all connected. And the biodynamics of movement, of human movement, kinesiology and all that stuff that came from my fitness world, it was very easy to bring that together to the TMJ world because, well, not only is this an important joint for, mastication and speaking, here I am moving my jaw as I'm talking to you, it's also an emotional joint, right? So lots of our stress, a lot of our life conditions manifest in body, manifestations and in presentations in our body. And one of those areas, as we all know, is the TMJ.
Yep.
So... yeah, put that together, fast forward to COVID time, when everyone was doing online stuff and learning stuff, their CE stuff online. I invested that time in learning yoga therapy. So basically how to help people with chronic diseases and chronic diseases and pain and just like post-traumatic stress disorder, past traumas and that sort of thing as they manifest in people's bodies, how to help people with that. Through the practice of yoga. And it's not just like the movements, but rather, it's a mindset kind of thing. Okay. And of course, all that ties into TMJ because in order to help someone with a temporomandibular joint disorder, you have to really listen to them and you have to help them get through certain obstacles in their life. So that's basically where my mindset is. I'm a radiologist, but I really do have a more holistic view of the human condition, be it the anatomy, the physiology, the psychology, and that sort of thing. And I bring that into my practice, and I bring that into how I also interact with other people, be it professionally, personally, and that sort of thing. So, yep, that's me.
I love it. Well, thank you. And that is why I love doing this, because I would be willing to bet most of the people who even do know you or know of you maybe have known that side of it. And I think that's going to open up a lot of exciting conversation today as well, because I too am a big believer in the holistic sense of what we do. And I think that's been a big problem, not just in our profession of orthodontics, as I am an orthodontist, and dentistry in general, but in overall healthcare, the siloed nature of it, right? You see one person for your TMJ or one person for your maybe PTSD, and they're not thinking, wow, how can we get other medical providers involved here? They just treat the symptoms of what they see. And that actually is how I went on my journey in airway. I wasn't trained in thinking airway first. I was trained to be a great tooth straightener. I'm a UConn guy, like trained by Burstone and Nanda. I mean, we are trained to be elite tooth straighteners. And that's how I came out. And I stumbled upon airway from ultimately, which we'll get much more into today, when I got my CBCT in 2014 was when I really started to understand it. But I have a very significant personal history in airway disease, and not on the obstructive sleep apnea side, but on the sinus disease problem. So one of the things I want to talk about today as well is how many of our dental colleagues tend to overlook the nasal anatomy and the nasal cavity and think it's all about a pharyngeal airway when we talk about airway. So I want to talk about that a little bit as well, because I'm someone who going through 2 sinus surgeries and a chronic allergy suffer. Mine's all in the nasal area. And so I have to deal with that. But that connectivity, I think, gave me a greater sensitivity to looking at my patients a little differently when I started seeing these younger kiddos coming in and realizing, yeah, why are we arguing over at what age we start this child in the context of only teeth and teeth alone? And that's really, if you look at the literature in the orthodontic world, the discussion over when we start treating patients is all dentally driven. It's, can I get them to be class 1 with an ideal overbite and overjet if I start now or if I wait? And the literature people cite on that, they back it like, well, there's no need to start earlier. And that's where I call for a paradigm shift in our profession to say, we need to start thinking about these patients as humans, as people who are more than just a class 1 occlusion with ideal overbite and overjet. So again, the similarities therein of your background in a holistic nature and the kinesiology and the inner workings of that. And we can talk a little bit too about what you see oftentimes and what we miss in 2D imaging that you see in 3D imaging with TMJ apparatus as well. So with that, to kind of kick that side off of the more granular details of why we do imaging in dentistry and radiology. If you could talk a little bit about how imaging has evolved over the years. I do have a lot of laypersons as well that listen to the show, but even a lot of professionals may not really know this. What are we looking at? What is imaging? Where did it start? You don't have to go all the way back, to the craniostat necessarily, but one of the things I find interesting is we started in 3D with craniometrics, with anatomy, before we went, dumbed it down to 2D. But what's the point of this? Why do we need these radiographs, and what are they trying to tell us on a macro scale before we kind of dive in and get more granular?
Okay. So, without going into the history and going back to, the guy who, imaged his hand and all that stuff. Mm-hmm. It's Röntgen, by the way. Yeah. We don't need to talk about that. But what we do need to talk about is, why are we imaging? And that is a very good question. We're not imaging just because. We're imaging for a very specific reason, and that is diagnosis. Okay.
Thank you. Yeah.
And diagnosis is the single most important thing that you're going to do, or any healthcare provider is going to do, or actually anybody is going to do when they have a certain issue going on. A problem. It doesn't have to be healthcare. It can be, a plumbing issue. We have to diagnose the issue so that we can fix it, right? Yes. And we have to seek the why. Okay, the why, not what's going on. You're not just looking at the open bite or the person's mouth breathing. You need to know the why behind it.
Yep.
Okay. A person has pain. The why. As we know, pain is very complex, especially craniofacial pain, where someone can have pain in one area, but the source of the pain is actually somewhere else. You can have a dental pain, but the actual source is the sinuses or the TMJ or even the neck and the muscles of the muscles of mastication and all that. So the why, pinpointing the reason why, is important. And we do have in our dental field and in medicine in general, we have clinical examination, and we have several other things that we do in order to figure out what that why is. But in our world as dentists, really a very big key of figuring out the why is using radiographic imaging. And the reason is that we're dealing mostly with calcified tissue, right? Calcified tissue, mineralized tissue, right? So our dentition, our teeth, our bones and all that stuff, even though if you were a layperson and you're looking at my teeth, you could see my teeth, right? But you wouldn't be able to tell what's going on inside of the teeth just because of all the dense tissue that covers up those areas. So similarly, the bone that the teeth are in, the alveolar processes. And I'm talking for lay people here, just making it very simple here. You can't see what's going on underneath that bone because you've got the bone, and then you've also got the gingiva, the gums, right? So you won't be able to see what's going on inside of the bone without actually looking through the bone. And we're not equipped, us people, human beings, are not equipped to see through structures unless you're Superman.
No, AI hasn't gotten there quite yet. Maybe
not
one
yet.
day.
Not yet. Yeah. So we need X-ray imaging specifically for mineralized tissue. And I know everyone's getting all excited about getting like MRIs and stuff like that coming into dentistry, using ultrasound, using things that are not radiation based, not X-ray imaging, in order to diagnose. But really, we've not gotten to a point where those are going to be diagnostic enough for our mineralized tissue based diagnoses. Okay. So the why, and there are so many different layers of whys. There's a reason why dentistry is now separate from medicine, although I think everything should be. If we go to dentistry, I think you have to have some element of medicine. And similarly, people who are going into medicine should have an element of dentistry in their curriculum, because these are not separate from the rest of the body. It's the beginning of your digestive tract, your aerodigestive tract, and your neurology, and all that is connected. We can go on and on and on about how all this entire system is connected. But that's the thing, is that unfortunately in today's world, we have separated out dental health. And I mean, it's on so many different levels, insurance and just in people's perceptions. So it's important for us to realize that this is part of the human body, and issues living in this area can affect the rest of the body. And that is part of the reason why we need diagnostic imaging to figure it out. Because once again, the mineralized tissue issue, you're not going to be able to tell just by looking in someone's mouth. You're a dentist, right? So some things you can, like the soft tissue stuff, but the hard tissue stuff need to be looked at with X-ray imaging. Okay. So, and X-ray imaging, I mean, I know you're saying the evolution. We started off, as you said, with that three-dimensional kind of, not so much what we have now, the sophistication that we have right now.
Sure.
We started off, like, let's say now in dentistry, with that, and then we moved on to two-dimensional imaging, the two-dimensional imaging being the plain films, the intraorals, the panoramics, the cephs, and that was fine, for what we were trying to do. But here's the thing, you and I are not Flat Stanley.
Exactly.
Have you read this book? Like for the kid, to your kids, or maybe you read it yourself.
Sure.
So we're not Flat Stanley. We're three-dimensional objects. We're three-dimensional beings with three-dimensional objects that are arranged in 3 dimensions all over the place. And there's a lot of complexity to that. And to try to squish the structures, these 3-dimensional structures, into one plane. And for those who are listening, and I'm clapping my hands together to create a flat plane with my hands. To try to look at a 3-dimensional structure in just one plane, like as thin as a piece of paper, that's really hard to come up with the full diagnosis. So enter 3-dimensional imaging, which has now, it used to be CT, and then it evolved into cone beam CT. I mean, of course, it's a little bit of a different physics are, behind it.
Can you actually explain, without geeking out on the physics side, but just a little bit more for the providers as well as some of the laypersons that are listening, what is the difference between CT and CBCT macro view? Because there is a lot of confusion about that. I think there was an article in the New York Times not that long ago when it was talking about the lack of safety of dental 3D imaging and using values of radiographs that were taken with CT imaging. So if you could just talk a little bit about the difference therein. Hey, everybody. Quick question. How many kids are you seeing who are mouth breathing, snoring, not sleeping well, maybe struggling with focus or behavior in school? Something's off, but we're never taught how to treat these patients early. So we wait for more teeth, wait for maturity, wait for the permanent dentition. Meanwhile, that child keeps suffering. Well, it's time to change that paradigm, which is why I've partnered with Dr. Daniel Camacho to launch the Early Orthodontic Treatment Comprehensive, a hands-on, 2-day immersive experience in Fort Lauderdale, Florida, this November 13th and 14th. You'll learn to identify these patients early, read CBCT images, coordinate with medical and OMT colleagues, and deliver proactive dentofacial orthopedic treatment. You'll study real cases, then watch it done live on actual patients. So you'll return home with the confidence needed to implement it in your practice on day one. And the support doesn't stop there. The registration fee includes my full 26-hour online course, a live remote case review in spring 2027, and a full year of discounted coaching. And if you enroll by May 31st, you can save $1,000 off the registration fee. We're keeping this intimate, just $20. So click the link in the show notes and grab your spot before it's sold out. We'll see you in Fort Lauderdale.
So I'm going to just make it super simple. The dose that you absorb is dependent on a few things. It's dependent on how long you're exposed, on the how powerful the source is, right? So the energy that's of the X-ray beam, as well as how dense you are, and how radiosensitive you are as well. So of course, if you're a child and you're growing, you're a little bit more radiosensitive than an adult, and the same thing goes for certain tissues that are more radiosensitive than others. Tissues that have a high turnover tend to be a little bit more radiosensitive than those that don't. And the other thing is that, okay, so with regards to time, all right, so the way that medical CT is acquired is that it's a fan-shaped beam, all right? So I don't know if you've had a CT done, like a medical CT done.
Sadly, from my sinus issues, too many that I
So you remember you kind of like you were on a gurney, right? And sure. and the bed basically went into the machine, right?
Yes.
And as you were going into the machine, there was something that was spinning around, right?
Yes.
That's the source, right? So it spun around several times. You probably didn't see it because it was encased, but it did spin around several times. Okay. So all that, as you're going in,
you got to hear it whooshing.
There's a spiral kind of thing. It's a fan-shaped beam, and it's spiraling around you. So it's like creating like a little spring around you. If you want to try to imagine what it looks like, as it turns around you. Whereas with cone beam CT, it's a different story. It's a lot shorter, and it's actually a cone-shaped beam, hence the name cone beam CT, surprise, surprise, right? So it's a cone-shaped beam, and it goes around the patient just one time, all right? It's got a lot less energy, okay? So basically, it's not going to be as high energy as the CT, and so the output, the X-ray output there isn't going to be the same. It's going to be it's actually much less than it is for medical CT. Okay, in medical CT, because of all these features, you also get soft tissue characterization, meaning that you not only can diagnose hard tissues, you can also diagnose soft tissues. Like you can tell the difference between muscle and fat and salivary gland and all that. You can also inject contrast to help you visualize things that have a lot of blood vessels in them, like malignancies, for example, cancers and blood vessel tumors, arteriovenous malformations, hemangiomas, that kind of thing, right? You can't do that with cone beam CT. You cannot tell the difference, not really, between muscle and fat and salivary gland and all that. And you can't tell what's going on inside the brain. None of that is visible on cone beam CT. And also you don't use contrast in cone beam CT. So a lot less radiation, but it's also, the indications for using this versus this are quite different. Yeah. So.
Sure. Yeah. Thank you for explaining that.
Of course. Yeah.
Because I think it is an area of confusion. I think loosely know as providers, but we probably could not explain it the way you just did in terms of the details of that. And it's important. It's important to understand that because patients ask this stuff. They want to know. They hear a chest X-ray is what, a couple thousand microsieverts or whatever, and they're like, oh my God, it's a really intense dose. They come into us, and I always train my team how to explain to the parents what we're doing here, because of getting back to your initial point. A lot of parents want to know, and that's why it's important for the providers to hear the why behind this as well, even though I know a lot of the providers are thinking, well, I know why we take them. But a key word you said that I don't think we focus enough on is the diagnosis, right? The diagnosis. I feel like especially in ortho, try to jump over that. And I don't want to point fingers at consultants because I've used them and I have a lot of friends that are consultants. I do feel though the consultant industry tries to minimize the time the doctor is in the room. And I almost feel like CBCT doesn't fit super well within that workflow of that sort of quick same day start, get them in, get them in treatment right away. Because I've done it. I've done practice both ways. And I know when I implemented a CBCT, it required a lot more time, energy, training, systems. You have to look through these images more efficiently. You have to, now that you see so much more, you have to know what to do about that, right? Like you said, when you make a flat Stanley, when you make this flat image, especially, I was just teaching the pediatric residents that I teach, where I'm the director of the ortho program of this pediatric residency. I have to teach them all their ortho, and they need to know a lot of ortho for their boards and CEFs and all that. And we were going through, just the other day, we were going through CEF training, and I was talking through these points, and I said, you have to realize this is a superimposition of the width of the head on a plate. And it's taking all of those structures and it's superimposing them, because one of the residents was like, I can't really tell where like the PTM point is or where articularia is. And I'm like, yeah, because it's kind of hard to see sometimes. So again, we'll come back to the 2D versus 3D, but I appreciate you going in a little more, at least explaining that part of it so people could have that context. So when we talk about the goal of diagnosis, why is there this debate in your mind? I know I'm not expecting you to have the end-all be-all answer, but in your mind, why is there such a debate still over implementing 3D CBCT at a lower dose, the machines that are at a lower dose, imaging into everyday clinical practice in dentistry, especially orthodontics?
Okay, maybe, and I think it goes far beyond, personal preference. But there can be an element of that, right? Mm-hmm. I'm like someone who has the mindset, hey, I've been doing it right. I've been doing this way all this time and it's worked for me. Sure. And, why move out of my comfort zone, right?
If it ain't broke, don't fix it, right?
Right. But here's the thing is that once your eyes are opened, it's very hard to close them, right? And once you start to see the diagnostic capabilities of three-dimensional imaging, it's really hard to go back and say, I wonder where this is on my CEF,
Yes, yes.
And I find this very, as a radiologist, I read both, right? I read whatever I'm presented with. Mm-hmm. But if I do receive a pano, a two-dimensional pano or a CEF, I kind of feel a little frustrated that I can't section it the way that I need to for the specific diagnosis that's expected of me. Okay.
Yes.
And because the two-dimensional imaging also has a lot of error associated with it, be it magnification, superposition, and others, that can also give an incomplete story, Mm-hmm. So here's a brief story. All right. So patient goes to the orthodontist, and has a pano done. This was a few years ago, and completes the orthodontic treatment. All good, right? And then comes back many years later with, I don't know, to revise or whatever it is, and they get a cone beam CT, and then they realize that this patient had an impacted supernumerary tooth. Mm-hmm. In the palate, that actually had a dentigerous cyst around it. So it's like it's a benign lesion, but still it's something that you act upon, Yeah,
it can be invasive, sure.
And they couldn't even see it on the pano because everything outside of the focal trough is eliminated. It's excluded. The focal trough being that band of information in which everything outside of this band on the image is blurred out. So things like this just make me open up my eyes to how limited two-dimensional imaging is and how it can give you a lot of fake outs as well. Mm-hmm. Whether it's the TMJs, which are a very important thing to diagnose before you start your orthodontic treatment, or the presence of pathology, whether that is in the arches or elsewhere in the craniofacial complex. I think we as dentists in general, whatever your specialty is, we really need to think a little bit more comprehensively. So your patient comes to you to be treated. And if you think of yourself as a tooth straightener, as you mentioned, If you think of yourself as a tooth straightener and all you're thinking about is the social six, hey, I mean, yeah, maybe 2D is right for you. But if you're thinking of yourself as a doctor, a physician of the oral and maxillofacial complex, then you need to be able to diagnose your patient's condition fully, right? Because the why behind a malocclusion is not just dentoalveolar. Some of it can be tangent, some of it can be airway, some of it can be other things going on in the patient's facial skeleton that you really cannot divine without having the appropriate imaging. Okay.
Yeah.
So the things that I think that keep people from moving from the 2D world to the 3D world, well, first of all, there is fear. Okay.
Yep, sure.
And fear comes in many, many layers. Right?
Agreed. Yep.
As you know, the fear, okay, let's just talk about the more altruistic one and that is, I don't want to expose my patient to too much radiation. Okay. And that's a very good thing. That's a very good thought, definitely. But unfortunately, well, there's a lack of understanding of really just how much radiation comes out of these units, and every day there are new dose reduction protocols coming out, not just in dental imaging, but also in medical imaging. Like you and I, when we were kids and we had a periapical or a bite wing done, they were using D-speed film and literally no collimation or anything like that, And things are very different these days. I mean, we went from analog to digital and all these other things, all these other factors, and every day things are coming along like that, even with 3-dimensional imaging. Okay. So the fear of radiation, like I said, yes, radiation, I'll be the first person to tell you radiation is a force to be contended with. Definitely we need to be, I mean, I've been to Chernobyl and you've probably heard my TED talk where I went and talked about that.
Yeah. I'll put a link to it in the show notes too. It's outstanding.
Thank you. So I completely understand and I completely know, by virtue of not just me being there, but this is my profession, my job is to know radiation and all the things that come along with it. And so there's always something that we need to consider here is that what is the risk versus the benefit?
Yes.
Okay. There's a risk. There's a very slight risk of anything happening. There's a risk, when you go to work in the morning, when you take your kids to school in the morning, right. There's a risk of getting into a car accident, In fact, the risk of that is higher than you developing cancer from a dental X-ray. But let's and there's no way I can actually compare and put numbers to that.
But point taken. Yeah, we can't live our lives. Right. We have to. That risk reward ratio is important to consider in all this.
And we need to be considering this in everything that we do. We do this whether we're thinking about it or not. We're thinking about. We are always considering we're moving on with our life without having to, like you said, just be stifled by this decision. It's happening in our head, whether we know it or not,
Yep.
But when it comes to dental diagnosis, and let's just talk about bite wings. So am I even going to go to 3D or anything like that? Let's say somebody has an abscess, periapical abscess, and we need to figure that out, right? And they don't want to get dental x-rays done because they're afraid of radiation. Well, the risk of that infection spreading, not just locally in the area and you losing the tooth and developing even osteomyelitis, you can have that bacteria spreading to the rest of your body, spreading through hematogenous spreads, through, meaning that it's going through your bloodstream into the other parts of your body, through like the soft tissue layers of your face, so the effect of non-diagnosis is a lot worse, or the risk of that is a lot higher than developing an issue secondary to radiation exposure, dental x-ray radiation exposure. Okay, so that's like the thought here. The diagnosis is important because it's going to prevent something a lot worse and a lot more likely to occur than the risk of, developing, for example, cancer with dental x-ray imaging, and that's like super, super rare to start with. But the risk of the spread of the infection, that's a lot higher, So so there's that fear of exposing someone to excessive radiation. Okay, so now we can get into why, like an orthodontist would be resistant to the use of common beam CT. Well, once again, my comfort zone is this, and this is the way I've been doing it all my life, and my forefathers have been doing it that way, my professors, but their forefathers weren't doing things the same way, right? And as technology evolved and the diagnostic capabilities evolved and our diagnostic pool has evolved, like now we have a lot more diagnoses and a lot more things that we need to look at and look for.
Yeah.
Okay.
Yeah.
And our understanding of how this three-dimensional anatomy lies in space and how it interacts with the different parts of your body, that all requires a different set of eyes, a different set of tools that enable us to come up with the correct diagnosis for that set of issues.
Mm-hmm.
So there's the fear, and the fear is secondary to, I guess, I could put this and phrase it very simply, I think, that the lack of knowledge. If you don't educate yourself and you're perpetuating some myths that are going on in the community or in your own head over and over and over again, you don't keep on reading the new literature, or understanding the underlying science behind certain technologies, it's going to be, you're just going to be stuck in that fear cycle. Okay. And it's not just in dentistry, it's in anything in life. Knowledge is going to give you power, and fear is going to take it away. It's just as simple as that, right?
Yeah.
Okay.
No, I think you're exactly right. There's a big fear component.
So,
I mean, the thing that I hear from people a lot too, actually, let me back up. So yes, I completely agree on the fear. I also think that the change, you nailed it, right? Like the change is hard. And when I implemented one of these in my practice, it was hard. It was not easy we had to change a lot of things, as I mentioned before. It's also, I think there's a couple other things going on that are interesting. Number one, it's money. I mean, I think people have a harder time monetizing. These machines are expensive. They can be twice the cost of a 2D PANCEF for an orthodontic office. And at the time I bought mine, it was about over 3 times the cost. It's come down a little bit. And that's an investment. And then you need different computer systems in your office to open these images with different capabilities than maybe you just have for your scheduling system. You need to have some sort of storage for them. So there are some logistical challenges therein as well. And then you add in, if you have practices that have multiple locations, right? You're now dealing with having to put one of these in every office if you want to have systems. And some people will solve that by having like a central office with their CBCT, and then the patients all go there. But in some regions, that's just not practical to have that set up. So there are some logistical challenges as well. And I think that's all of these together is why a lot of people do oppose it. Actually, I should add one more. And this is just my thought. I don't think orthodontists sometimes want to know all that there is to see, to be honest with you. And look, I'm an orthodontist. I get to say that. I've paid my dues. I've done this. I'm one of them. You can kind of make fun of your own, right? And more than you can others. But I don't think I think there are some orthodontists, actually, I'm quite confident there are orthodontists who just don't want to see. I just was looking at a case with a doc I coached recently, Dania, and the initial images, some of these roots were like out of the bone. No one to touch this patient. Like it was on a CBCT. Literally, like the upper right canine in first bi, the lower right molar had a little bit of a dehiscence. There was a fenestration on one of the canines. And I said, I think orthodontists are a little worried because I've had it happen to me where you take a post-treatment CBCT and you realize some of those roots are not really soundly in the bone. And I'm like, oh my gosh, like everything looks beautiful. The case is perfect. Everything looks great. And you look and we almost maybe don't want to see what we know might be there. Or I don't know if we're worried about liability or what, but I think it's just interesting to point out. And when it comes to TMJ as well, you said about, not really understanding it, not having the knowledge. We may not realize what we're looking at, and we may not want to see some of the remodeling that can happen during orthodontic treatment or some of the changes that can happen during orthodontic treatment. So I don't know what your thoughts are that. I don't want to put you in an uncomfortable spot.
This is, you can add to that. I don't want to be responsible for what's on the scan. I don't want to, so I don't want to learn anything new is what I hear,
Yeah.
Because like once you start scanning anything beyond just the dentoalveolar complex, you are going to get into other structures that we as dentists are not very comfortable with.
Yes.
You're going to get into skull base. You're going to get into the airway. You're going to get into the cervical spine. And that's a responsibility for us to broaden our knowledge base, because your eyes are only going to see what your mind knows. Okay. Yeah. And if you don't know that particular issue, that if you don't have like a bank of information that covers that information, your eyes are simply not going to see it. It can be right in front of your face.
Yep.
And we've all had this kind of an experience where we're in dental school and we're reading the X-ray imaging that was given to us, and our radiology professor points something out to us, and all of a sudden it comes into huge focus, and it's all that we can see because our eyes didn't pick them up because our mind didn't know it, right?
Yeah.
So there, that in addition to people just don't want to be. I think they're worried about what they may find, and what they may find may actually change the way orthodontics is practiced.
Yes.
And that is a big can of worms that I don't think many people are ready to tackle. To start to think more of a three-dimensional way of treating patients. I mean, I know you're moving teeth in like different directions and all that stuff, but really, when you see it, it's hard to unsee it, as you know. When you see things in 3D, it's really hard to unsee that, and to unsee some of the complications that may be secondary to you not getting your vector forces correct, right?
Mm-hmm.
So, yeah.
Or your treatment plan correct because you didn't have the diagnostic information to help you. And that's the thing I say to my ortho colleagues all the time. Like, yes, you're going to see more. Yes, it can be a little intimidating at first. That being said, once you embrace that change and that challenge, which is a leap, I was so much better as a clinician when I had more diagnostic information. I, of course, right? Like you just said, if your mind doesn't know it, you're not going to see it. So once you start to learn more about this, you become better. My cases were better. I was so much more astute in my diagnostic capabilities that I could really predict a lot more of what was going to happen. My cases started treating out faster, more efficiently. I started having fewer surprises because I was able to see transverse discrepancies. We'll talk a little about that in a second, that when you're just looking at a sagittal lateral 2D image, really tough to tell some of those osseous transverse discrepancies. I also found that that's how I got into looking more at airway. Actually, my wife literally just asked me this coincidentally not long before we hopped on the podcast. She was actually listening to a previous episode of my podcast, and she's like, when did you really start thinking about things more airway? I'm like, it really was just before, and then when I got my CBCT in 2014. Before that, Dania, I was always kind of against extracting teeth and caving everything in, just more from an aesthetics and functional sense. I always knew they weren't crowded for big teeth. Very few people are. They're crowded for small jaws. So I was just like, well, why don't I fix the etiology? I don't want to, treat the symptom. That was really kind of why I was doing more early expansion and jaw development and growth and development. It wasn't for airway. And I've said this many times. I'm kind of embarrassed to say that a lot of parents would ask me, like, Dr. Mike, do you think it's a coincidence? Like, they don't snore anymore. Like, if we're all in a hotel room somewhere, like he used to keep us up all night. He's not. Or do you think it's a coincidence? Like, I couldn't get him out of bed in the morning and he's getting up better ever since we've been expanding him. And I would literally say to them, Danny, I'd be like, I guess it can't hurt. Like, it's connected to the nose. I'm making it bigger. I always never want to tell patients. I always tell my residents, you never tell a patient or a parent something. You don't lie. You don't tell them something you don't know. So I was like, I can't be hurting them, but I don't know for sure. And it wasn't until I started digging more into the literature and got my 3D, and then it started to click. I would see these patients before I started treating them in 3D and then after. And they looked like different humans. The anatomy, everything down to the nasal passageway patency, the pharyngeal anatomy. And again, I know we're not diagnosing, and we'll come to that in a second, off of the CBCT. That being said, there are so many anatomical markers that can tell you. And then the subjectivity of asking the parent and the patient how they're doing. And it just started to make sense to me. Oh my gosh, I'm having so much more of an impact than just like straight teeth or in this case, not extracting in a phase 1 and being able to do it with arch development. So yeah, I think that's a big part of it is not wanting to see what we maybe don't want to deal with.
I think the problem is that if the orthodontic community embraces 3D and starts to change the way that they look at their patients and maybe treat their patients, they're going to have to rename themselves to craniofacial orthopedists, which, by the way, is what you guys are. You're not.
1994, they changed the name of our profession with the ADA to orthodontics and dental-facial orthopedics. Why do we not think of ourselves as that? Let me give you my reason for why. We've never spoken about this, and you can tell me you disagree. I say this publicly when I speak in front of large audiences full of orthodontists. I think because orthodontists make a lot of money straightening crooked teeth, and it really works to have that system in your practice where we hone it, right? We hone that system, and it's like, great, I'm used to this. I know what this is. And I'm not saying it's wrong. Like, you're doing a great service for these patients. But when you start talking about thinking differently, you're now taking more diagnostic time. Now you have to start changing your treatment approach. You have to maybe get in there a little earlier. You have to try to guide growth and development. It upsets that apple cart, and it makes it more difficult to monetize for a lot of people. There's this whole myth, like people do phase 1 or earlier treatment because it's more profitable. I've done it both ways. I'm telling you, until you really get good at it, you can lose money doing more early treatment because it takes more time. You tend to have more costs on appliances and whatnot. It's much more profitable just to straighten crooked teeth in teenagers and adults, truthfully. And again, I've been there. I can say that. I've done this for a long time. So yeah, I think that's a big thing that people, it's kind of taboo to say it, but ultimately it's just kind of what I've seen.
Well, it's the society that we live in, and it's not just orthodontics. It's dentistry in general, if not medicine, if not every single practice out there. We've got an assembly line situation.
Yes.
And we see it. I mean, I see it when I go to orthodontic offices. I just visit with my friends, and I just see how the process is. And it's really hard to fit in the proper diagnostics into an assembly line kind of practice. And I get it. I mean, we all need to make money. Right? We all need to live. But the thing is that this is a responsibility of the human life in your hands. Somebody is coming to you with their child, and they're trusting you with their child. Yes. So what are you doing with that trust? Of course, you may think that you're doing the right thing, the best thing for them. But truly, unless you sit down and spend time with the diagnostics, that is not going to be the best thing for the person, because everybody's different. You don't treat all class 2s or class 3s or class 1s or whatever, malocclusions, whatever it is. It's not a cookbook kind of situation, where you open up, what's your book? What is it? Graeber, or I don't know.
Graeber, Prophet, Contemporary Orthodontics.
Whatever it is.
Yep,
I had to look at the name of the book here. I have it. Yep. You don't just open it and follow a cookbook recipe. You have to really look at the person in front of you and look at the unique set of situations that led them to where they are right now. And the body keeps a chronicle of your life. It reports it in your soft tissue action and in your bone remodeling, And if you're not acutely aware of that, you're not going to see that as in your patient, and you're just going to keep on doing, the tooth straightening thing, the social 6 thing.
Okay. Yep. I think that's why a lot of younger providers, as far as I've seen, and I coach and teach docs of all ages. I think that's where a lot of the younger providers tend to be much more open to this, because they haven't been involved in that system, that assembly line machine for a while, because that's not what a residency is. So they come out, and I think all of us come out altruistic, wanting to do the best for our patients. And I say that openly and honestly. I really don't feel that even the docs that I may be critical of that are still practicing the more traditional way, tooth-only focus, I really don't believe they're doing it with an intent to harm or not do the best for the patients. I really mean that.
Of course not.
It's just right. It's just human nature that once you do something a certain way for a considerable amount of time, and it becomes comfortable and profitable, and you have your systems down, there's very little incentive to change at that point if it's working. So whereas the younger docs, they're still kind of like learning, they're figuring this out, because when you say, just even to a layperson, I could see you in 3D or I could see you in 2D. Which would you rather me see you in, right? I mean, most people, if you're talking about the decision you're going to make for their healthcare, are going to say, well, I want you to see more of me if at all possible. I mean, we have 4D ultrasounds now for in utero. I think, and I say this too a lot of times, I'm like, name another profession that is fighting to see less of their patients. I can't. And I tell people, email me if you can think of one.
It's astounding.
Most professions are trying to see more of their patients.
It's astounding. And here's another issue that I see is that, when it comes to medical imaging, no one bats an eye. No one bats an eye. Like if your doctor tells you your kid needs a CT of the chest, are you going to argue with him or her?
Right. It's a good point.
I think part of this also is the perception of what we are and the perception of what we put forth as what we are. Are we doctors?
Yes.
Are we physicians of the oral and maxillofacial complex? The ones who are the most knowledgeable in the diagnosis of the craniofacial complex of the oral cavity? Or are we tooth straighteners? Or carpenters or plumbers? I no disrespect to carpenters and plumbers, but if you brand yourself as an esthetician, once again, no disrespect to estheticians, but obviously the amount of education that goes into becoming a dentist is a lot different than what, but if you brand yourself as that, you're going to be seen as that. And unfortunately, in our world, when you look at all the advertising for dentistry these days, teeth in a day, nice smile, white teeth, it's not about that. And we really need to change the way that we speak about ourselves so people will see us differently, or otherwise they're going to argue with us just as they would argue with their, with their hairdresser if they don't like their haircut,
Right. Completely. Right. Well, that's such a great point that we haven't created the value in their minds of why we need to see more, because we've made it like in the ortho world, we're just straightening teeth. And they're like, I had braces 30 years ago. They look the same now. Yeah, you can do it in plastic, but it's the same concept. You're straightening teeth. And actually that gets to the next point of why do you feel that we can do so much more for our patients when we see them in 3D when they're young? And that gets into the whole, like, how early do we start taking these 3D images? And the ADA and the AAPD say that you have to have a very specific reason to take a 3D image on these younger patients. So I think there's some disconnect there. So I'd love to hear your thoughts on when we get to the younger kiddos, even just, start 4 or 5 years old or whatever that age, where does that risk benefit scale lie? How can you kind of provide some clarity for the practitioners out there who are confused about the parameters for taking 3D images? Well,
not just in kids, in adults as well. If you don't need it, you don't take it, right? So every single, what I'm about to say right now is going to basically make that assembly line practice not a very good, it's going to make it seem not very good, okay? And that is, it's going to clash with it. Sure. And that is every single radiographic image taken at the dentist office needs to be preceded with a clinical examination. And in today's assembly line type of practices, what's the first thing that people get done? They get their x-rays done, Yes. Yeah, pictures and x-rays. Yep. X-ray imaging done, right?
Yep.
And that's not how we're supposed to do things, and in my radiology training, we are taught to drill home the fact that there's no such thing as a routine x-ray image, right? We do need to look at our patients, and we look at them fully, and we look at what's going on with them in particular that day to determine whether or not they need the imaging that they need. And I'm just going to give a broad example. If somebody has temporomandibular joint disorder, so TMJ disorder, okay, they have pain in their TMJ. That pain can be muscular, can be just the muscles of mastication working overtime, and that's not something that you need to use X-ray imaging for. So why would you expose the patient to radiation for that? And that could be easily rolled out by examining them clinically. Examine them clinically and figure out what's going on. And then the type of imaging that you need. Not everybody needs an FMX, or a pano,
Yep.
When they come into your clinic, you examine them, you see nice pristine teeth. Why would you get an FMX, right?
Exactly.
Yes, of course. And I know that there are situations where things show up on imaging and all that, but if you're really worried about X-ray imaging and radiation, then you also have to think about that. You're not just going to go and do the cookie cutter cookbook X-ray, imaging protocol for everybody that walks in through your door. So going back to kids now, once again, it's case specific. You have to look at that patient. You have to look at them fully, because sometimes the why, the diagnosis isn't in your hands as a dentist. The why is in somebody else's hand, medical professional, somebody else. It could be a chiropractor that unlocks the key to why this patient is not doing so well, So if it's not going to be you to be unlocking this why, then why are you exposing the patient to your radiation? And then maybe they're going to go to somebody else and then that person decides to expose them again to whatever they think is needed for that specific diagnosis, So you see what I'm saying is that clinical diagnosis is the most important. That is key. It's a key part of the diagnostic cascade, right? Looking at your patient, spending time with your patient. And that time, I know time is money, but time is also trust. Time is care. That's how you spell care, Time.
Like
right?
that.
Okay. And that's how your patients also perceive that you care.
Yes.
If you take the time to listen to them and look at them and really see them, not just quickly chart and, and move on to the next patient and jump to the next operatory and all that. Anyway,
essentially taking a CBCT, a low-dose CBCT on every 4-year-old before you're examining them, not the best idea, because you're basically not, at that point you could get into a risk-benefit discussion like we talked about. But doing a clinical exam, determining the 4-year-old is a chronic mouth breather, they're growing with abnormal face shape, and they have some sort of craniofacial alteration, you look at that patient and you're like, there's something going on here in this kiddo that definitely the reward outweighs the risk of some of the radiation, minimal that it might be relative to 2D difference, to get some more information on this kiddo, because maybe they have lymphoid tissue obstruction, maybe they have chronic allergic rhinitis, maybe we need to send them to a medical colleague, maybe they have a tongue posture that is an issue and you can't really tell in 2D, so in that 3D you can really see the transverse relationships of the teeth and the bone. Is that more what you're saying?
So let me just I'll give an example here. Okay, let's say we'll use the 4-year-old analogy because that's what your 4-year-old's example, because that's what you're bringing up here.
Sure.
So a kid comes to you, can't breathe through their nose. They have a mouth breathing, a posture. There's developing this adenoid facies kind of situation. So now, what does that say to you? You as an orthodontist, what's it telling you? That morphology, that phenotype, what's it telling you?
That their growth is potentially altered from the way they're breathing.
Right. Okay. So what's it telling you specifically? Where is the alteration, or what is the why? Do you know what the why is?
I don't know yet I don't know what's causing that obstruction at this point.
So if they're opening their mouth, it means that something's going on with their nose, right?
Or their nasopharynx, or most likely.
Specifically, like everything from the tip of the nose to the level of the hard palate. Basically,
exactly.
So nasopharynx, nasal cavity, sinuses, and nasopharynx. Okay.
Yep. Agreed.
And can you agree with me that anything that may occur in that area is going to be, or it's going to have to be treated by somebody else?
Yes.
Okay.
Completely.
Now, there's a whole list of things that can occur in the nasal cavity. A whole bunch of things that can obstruct your nasal breathing. Right. You can have a nasal valve obstruction. You can have a deviated septum. You can have anomalies, the actual size of the nasal cavity, which is something that you can possibly contribute to helping with if you are doing the expansion.
Yep, exactly.
You can have sinusitis, rhinosinusitis of different varieties, acute, chronic, bacterial, allergic, viral, fungal. You can have tumors, you can have polyps, you can have in my book, I've got like a whole bunch of things that you can actually have happening inside your nasal cavity that can give you the same adenoid facies, the same mouth breathing posture, in addition to adenoids, right? We call it adenoid facies, but it's not just adenoids that are going to cause that presentation. Okay, so everything that I just mentioned here, except for like the nasal cavity dimension, is probably going to be dealt with somebody else. So what I would do, honestly, in that kind of a situation is that I would refer this kid to an ENT, okay? I'd refer the kid to the ENT to figure out what's going on inside the nasal cavity, and if there's anything from there back to the adenoids. What's the why? Because they're a lot more equipped for that diagnosis and for the treatment, okay? So for example, let's say you went and got a combi CT of the craniofacial complex in that kid, all right? And you find something that looks like a tumor, but you can't figure out what that tumor is because you can't characterize it with CT, with the combi CT.
CBCT.
All right. So this kid's going to go over to the medical side and get a medical CT. And if they're suspecting malignancy or something with an AV malformation, whatever, they're going to inject contrast. So why would we expose the patient twice? Okay. So that's just that.
Can I ask a clarifying question?
Sure.
So one thing that I find, though, is, and I hear this not just from patients that I deal with, but with others, is they'll send that patient to the ENT, and the ENT will use a rhinoscope. They will not put a scope up that kid's nose. And I find that a lot of the ENTs are saying to the orthodontists, and I've had some on my show saying this, we want the orthodontists to take a low-dose CBCT on that patient. Some ENTs have them in their office, but not a ton. And I was shocked, Dania, when I started asking parents when they came back a few years ago if the ENT put a scope up the child's nose. And I mean, it's not quite zero, but they're not doing it. I don't think they want to in their office. I mean, a lot of ENTs, unless they really specialize in pediatrics, I don't know if they want to. I mean, I've had a scope in my nose more times than you can even count for all my sinus issues. It's not the most fun thing. And so I found that on those cases, what I found happened was when I took the low-dose CBCT, or if it's a patient of the residence, and we then send the images or even screenshots of what we found to the ENT and or allergist, because that would kind of help me know sometimes if it's more in the nasal cavity, turbinate hypertrophy, looks like it's going to be a chronic allergic rhinitis. Obviously, I'm not diagnosing that, but I just see the signs and symptoms. So I would tell the parents, hey, look, I think Johnny really should see the allergist because he can't breathe through his nose, and you're telling me he's stuffy all the time, and I'm seeing a lot in his nose, but at the back where the adenoids would be, he looks clear. So it helped me know, is this an ENT or an allergy thing, number one. And then number two, I found that the ENT and the allergist so relied on my images, and still do rely on my images, that it let them get that view when I would send some screenshots, and they were calling me thank you so much, because now I was able to see more. So I totally see your point of it, but I'm kind of as someone who's teaching young residents this too, we struggle with the fact that most ENTs, they don't, and allergists, they're not sticking anything up the nose but a rhinoscope.
And thus is the whole issue with the elephants, the blindfold scientists and doctors diagnosing different things, and not communicating with one another. Okay. So you have a good relationship, it looks like, with your ENT, right? And I think everybody here who's listening here, every orthodontist, every dentist who's listening here needs to reach out if they're in this world of, trying to figure out what's going on with the sinuses, nasal cavity, and they need to reach out to their ENT and create those bonds and those relationships.
Thank you.
Okay.
Yep.
So great that that's happening with you. Unfortunately, I've seen it too much where people are imaged several times because, this is a dentist image, blah, blah, and they don't like that and they want to do their own imaging,
Got it.
So thinking of, so both, I mean, it would be great if everyone had that same communication that you have with the ENT and that same respect also. But unfortunately, also we have people on the medical side kind of poo-pooing what we do, right? And poo-pooing our diagnoses. And but anyway, long story short, in the end, let's go back. 4-year-old comes to you in your clinic and you got to figure out what's going on. Clinical evaluation, figure out what's going on. In the end, if you have to push the button, you can push the button. It's going to expose them to a minute amount of radiation, but guess what? It's going to be the same amount of radiation as if they were living on Earth for a week.
Right.
As you know, we all live here and we're bombarded with cosmic and solar and terrestrial. And we're just sitting here in a radiation soup, right?
Right.
And we're not...
Even more so if we hop on a plane or live at high altitude, right?
Yeah, or, sunbathing and, everyone has their phone and their iPads on their laps, so we're not...
Yep.
So, I mean, there's all types of radiation all around us, right? Some of it ionizing, some of it isn't. But the thing is that, once again, if the diagnosis needs to be met, then the risk of the radiation definitely is lower in priority than the actual diagnosis, because the diagnosis is going to open up that why, that, okay, it's going to basically close the can of worms or actually close the labyrinth that the patient may go through if they don't have the why. Okay.
Yes. Yep.
And that I've seen as well, where patients are like going to every single specialist because of their headache, in the end, it's a toothache or something, or some kind of referred pain pattern, and all it took was somebody who knew about something about this referred pain pattern to come up with a diagnosis and solve the problem.
Yep.
So.
Yeah. Yeah. I want to just read to you what the recent AAO white paper update said about this, because I think we would both agree we're not using CBCT to diagnose when it comes to airway, sleep disorder breathing, or obstructive sleep apnea. But I want to read you their comment that they said, this is a quote. In summary, imaging of the upper airway using CBCT or lateral cephalograms has no diagnostic value for SDB risk assessment or diagnosis. And they cited reference 34, and I recently put out a commentary on the AO white paper. It was about a 90-minute commentary. I'll put a link in the show notes to that. It was something I did to just kind of talk about and break down this document. But this reference 34 was a lengthy document. It was 624 pages, 2,157 references. It's a big document. It's a consensus statement on obstructive sleep apnea. But in that statement, Dania, they literally said, and I'm reading this as a quote from that reference that they cited, similar to cephalogram, CBCT can be of value as an adjunct in the anatomic evaluation of OSA. And I don't think what reference 34 said is very controversial. I don't think it's a stretch to to say we can evaluate the anatomy differently when it comes to surface area, cross-sectional area, angles, shapes, volume. We're not making a diagnosis. It's not like I never was one. I mean, I look at the pre and post volumetric analysis of the pharyngeal airway for my own clarification. It's like, hey, did the change in shape or size? But I never was one to measure that and say to the parent, oh my gosh, the cross-sectional area is X. Your child has an airway problem or is more likely to have an airway problem. I never, for many reasons, which you can explain much better than I can, bought into that, because it is a static image and they're upright and there's all these, the tongue posture, there's all these head posture, neck posture, all these other factors. But to dismiss it as we can't glean any information to help us in understanding if this patient suffers with airway compromise, I honestly couldn't believe they wrote that. So I would love to hear your thoughts.
I mean, this is not the first time literature is misquoted in the literature, right?
Right.
I mean, we have to just be very careful when reading anything. And I know this is supposed to be some a position paper by a very well-established and well-respected organization. But, we're human and sometimes we have our biases, and we have, I have my biases, you have your biases, and they have their biases, right?
Yeah.
So sometimes we want to confirm our biases. And unfortunately, from what you're saying right there, they did that without really reading reference 34. But anyway, I mean, let's not, I'm not going to criticize anyone's work. I'm just going to talk about what I do then. Okay.
Yeah,
and
please. That's what, exactly.
All right. So in order for you to breathe, right. Well, let's actually take a step back. What's the most important thing that you do with your face?
Yeah, breathe.
Okay, to breathe, right? Try not to breathe for 2 minutes. You're dead, right? Mm-hmm. And you need to be able to breathe, not just breathe, but you need to breathe the right way, right? And I kind of talked to you about how your body keeps a chronicle of your life, like what you do, your habits, the way that you sit, the way that you act, the way that you eat, the way that you just interact with the world around you. Your soft tissues and your hard tissues interact with one another, and your bone remodels to fit the function, like form follows function, right? Mm-hmm. And similarly, your face, the most important thing it does is breathe, right? So it needs to breathe in a very specific manner in order for your face to develop the right way, right? Mm-hmm. If you're not breathing in the right way, your face isn't going to develop the right way. And one example of that is the mouth breathing and the adenoid facies that we know, the long face that comes along with someone who can't breathe through their nose and always have to breathe through their mouth. Okay. So the craniofacial complex is in a constant flux, just as the rest of your body is. And there are several parts of it that are involved in this upper respiratory tract function, right? So, and it's funny because like I once had an argument with an orthodontist when I said upper respiratory tract, they're like, I'm not a pulmonologist, I'm not an ENT, I'm not responsible for this upper respiratory tract. I'm like, are you kidding me?
Right, like the mouth, hello?
Yeah, well, yeah, aerodigestive, there's a reason why it's called aerodigestive, right? So there are some commonalities, some areas, some pipes that they have in, that they have to both pass through the air and your food.
Well, and the opposite side of the palate is the nasal floor. I mean, it's to think that it's dissociated and we have zero impact. It's just shocking. But hey, sorry, go ahead. I digress. Go ahead. I don't interrupt you.
To each his own. In the end, when people are married to a thought, it's really hard to divorce them. When
so true.
When
so
they're,
true.
It's like religion. When you've got that religious conviction that something is correct, to try to convert you is really hard. And I think, in general, when dealing with people who have differing thoughts, it's important for us to come with an open mind and to listen, and to listen wholeheartedly,
Yes.
without letting the ego come through. So I'm here now. I'm going to be talking here with trying to not let the ego shine through because this is what I do, right?
Right. And we all get passionate about it, and then that leads to our own biases on it. Yeah.
Right. So just simple anatomy. And I think if more of us studied anatomy just beyond that first year of dental school and did it regularly, our world is going to change as diagnosticians, as clinicians in general. Okay, so there are several areas that your nose can be obstructed. And I mentioned this before. It's not just going to be the adenoids. There are several things in there that can be very easily seen on cone beam CT. So your ENT, he's right. The cone beam CT gives you a lot of good information about the hard tissues. Okay, and the example that I gave of a tumor and that's kind of rare. In the end, most of the things that we see in our practices are like with regard to nasal obstruction are going to be things that are bony, the deviated septum, the concha bullosa. The sinusitis is soft tissue, but there are patterns that kind of tell you that what type of sinusitis it is. And the presence of adenoids, because you can see the adenoids versus the bone versus the air, like the interface of that. So you can see how large those are. Okay. All that is in the non-collapsible part of the upper respiratory tract. All of that is encased in bone. Okay. And you can't see that unless you go in with a scope or you have bony imaging, right? You can get an MRI, but how easy is that, right?
And the turbinate anatomy, if just to add in the turbinates, I can't believe how many hypertrophic turbinates I see on these young patients today. It's hard to
allergies will do
comprehend.
that, right?
Of course, yeah, with the allergens, but it's really, it's over 50%. I mean, whether or not the clinical significance requires intervention from the medical provider or not, but it's common to see these kiddos with mucus rimming in the sinuses, mucus pooling in the nasal cavity, inferior turbinates that are really enlarged. It's really common, and we're down here in Southwest Florida where allergies can be really bad. We see it all the time. It's unbelievable.
And with all that, when someone can't breathe through their nose, they're going to open their mouth. So let's talk about what happens when you open your mouth to breathe. For those who are not dental, who are listening here, if you open up your mouth to breathe.
And even for the dental, may I interrupt? Because my dental colleagues don't believe it.
Perhaps.
So please.
Okay, so first of all, why are we breathing through our nose? Okay, why are we breathing through our nose? Why is it important for us to breathe through our nose? For several reasons. Okay, we'll talk about the physiology first. We'll talk about how it's important to condition your air. Right. So there's temperature control that has to happen. Right. There's temperature control. There's humidification. There's filtration of whatever stuff, pathogens and particles and all that stuff. That's what your nose hairs are for. And the mucus is for, and also the turbinates themselves. And you also have to mix that air up with some nitric oxide. Okay, so your sinus mucosa secretes nitric oxide, and that nitric oxide, not nitrous oxide, for those who are thinking of laughing gas. No, although that would be fun, wouldn't it?
Right.
That nitric oxide is important because it increases oxygenation at the level of the alveoli in the lungs. All right. So to have that mixed in with your air is actually a very good thing for you.
Which doesn't happen, just so everyone understands, does not happen when you mouth breathe, just for clarity.
Exactly. So if your nose is blocked and you're breathing through your mouth, you don't have all that, the temperature control, humidification, filtration, all that stuff, in addition to that nitric oxide not mixing in with your air. Right. So there's that. Okay. And then the other thing, that's the physiology of the nasal cavity. The other thing that needs to be considered is just what's going to happen with your face. Remember, form follows function. So if you're going to open your mouth to breathe, that's going to take your tongue and drag it downwards. Okay. So for those who, are not dentists, who don't realize that their tongue actually lives in their oral cavity, it inhabits the oral cavity, and the space that you have in your oral cavity, inside of your jaws, inside of your teeth, that's the house of the tongue. Okay. And the tongue is attached to your lower jaw. It's not attached to your upper jaw. It's attached to your lower jaw. And when your mouth opens to breathe, the tongue is going to descend. It's going to move downwards and away from the palate. Now, as I mentioned to you before, we've got this physiology, or actually this remodeling thing happening, soft tissues and hard tissues and the chronicle of your life and everything. And the thing in your face that keeps your jaws broad is the tongue being up against your palate.
Yes.
All right. And you also have the muscles of your cheeks pushing inwards. So the tongue pushes outwards, the muscles of the cheeks push inwards. So you've got a push of war happening, and everything is in homeostasis. Everything is in a good neutral position, right? In a place where
you're closed.
When you're closed, that's when things are normal. Now, if the tongue descends because you're always breathing through your mouth, you have nothing to oppose those cheek muscles, those flexinator muscles pushing inwards, and your jaws are just going to get narrower and narrower. And that is going to not just give you narrower jaws, it's also going to give you crooked teeth, because there's no space for the teeth to be aligned nicely in the jaws, right? So someone may have crooked teeth and they're coming and they're saying, please fix my teeth. And if they just fix your teeth and not deal with the underlying why you have crooked teeth, they're just going to become crooked again. If you can't breathe through your nose and you keep bringing your tongue away from your palate, and, even if they fix it, it will regress. It will go back to the relapse, to the way it was before, if you don't deal with the why, right?
Absolutely.
So we talked about the physiology, and we talked about the balance, the neutral space in the mouth, where the teeth should lie, with the good balance between the muscles on the inside of the jaws and the muscles on the outside of the jaws. Okay, so not just the jaws are the only thing that are going to become narrow. Your whole face is going to become narrow, because the same bones that support your upper teeth, the maxilla, you've got 2 maxillae, right? Are all the way up to here, all the way up to your forehead. They connect to your forehead. They connect to the bottom of your eyes and part of your cheeks. So all of that becomes narrow as well, because the remodeling isn't just going to be in that one area. Everything is going to grow long and narrow. Okay? You grow long and narrow, your jaw is down, your jaw is backwards. That's going to push the tongue not only downwards, it's only going to take the tongue backwards. It's going to take it back into the air tube, the pharynx, right? And that is going to increase the likelihood of the tongue becoming displaced backwards when you're sleeping. Okay. So I think I've covered everything here. Is there anything that
Yes.
Yeah. Okay.
When everything happens that you just described, the end result is the majority of those patients, yes, there can be certain phenotypic variation, but the majority of those patients are going to present with very crooked teeth. And I say all the time, the whole extraction debate in orthodontics, to me, is not a debate over whether extracting teeth causes airway problems. It's a debate over whether extracting teeth ignores the airway problem that was underlying the etiology of the crowding.
Right.
And that's, and what gets back to where we kind of started this conversation, was the siloed tooth straightening aesthetic concept of orthodontics, focusing only on that instead of that beautiful description you just gave of the physiology of appropriate proper nasal breathing and why that's important is, and I want to read you this part too, this quick quote from the white paper update. They also said, no currently known craniofacial phenotypes can identify the presence of sleep disordered breathing. I don't know why they said that, because it's interesting, Dania, in the first white paper, the 2019, they actually acknowledged numerous craniofacial phenotypes that can identify it. And then back to reference 34, I won't read it, but they did cite many craniofacial phenotypes that are related to chronic mouth breathing, obstructive sleep apnea, sleep disordered breathing. So it's just kind of interesting how I think you've explained it so well. There's so many biases, and it's sort of this confirmational bias where we get doing things a certain way, and it's just really hard to think differently, because everything you just described is, to me, the essence of the diagnostics that every orthodontist should be going through in their patient, right? I mean, instead of just looking at a sagittal 2D Ceph and going, oh yeah, there are little, A points this degrees and B points this degrees, so let's throw a headgear on them or whatever, right? I mean, think of the difference.
Right. Well, I mean, add to that is that if your tongue is displaced backwards into your pharynx, you have to be able to breathe, and you're going to possibly move your head forward. And if you move your head forward, then you're throwing the balance of your entire body off. And the beauty of CBCT is that it's going to show you all these things that I just talked about.
Yes.
It will pinpoint the why, so that you don't go chasing after a symptom. You'll find out exactly why someone presents this way. And even for those who are naysayers of airway, open bites, asymmetries, malocclusions, things that are traditional orthodox, if you don't figure out why a person has an open bite, that open bite is just going to relapse.
Yes.
And the why is so much easier to find when you can visualize this three-dimensional structure, this three-dimensional object, this three-dimensional organism in 3 dimensions.
I'm going to let you have the last word with that. There's no way I could have said it as well as you just did. That is absolutely perfect. And I thank you so much for your time, your expertise, your clarity of thought on this, explaining it so well. And with your background, it's great, because one of the nice parts is because you're not an orthodontist or even practicing clinically in dentistry in that sense where you're dealing with the day-to-day of dentistry, you have an interesting perspective where you get to see what all of the dentists are doing because of the position you're in, helping a lot of people and reading a lot of images. And so for you to synthesize all of that and say, hey, look, there are these commonalities that exist in our patients, and we need to get back to being diagnosticians, I think is kind of the core message of all of it. Would you agree with that?
Well, absolutely. Diagnosis is dentistry. I mean, that when I applied for a dental license in Florida, and I told them all I'm going to be doing is diagnosis, they told me diagnosis equals dentistry. Thus, you must have a dental license. So, all right. So, meaning that it's a crucial part. It is really the very first thing that anyone should do before they see anybody. The solution to the problem doesn't come from, okay, we'll try this and then try that. And, it comes from the diagnosis.
Yeah,
and
I love it.
Once again, the cone beam CT is just like a wonderful way of figuring out just what's going on so that we can come straight to the diagnosis and fix the underlying issue. Okay.
I couldn't agree more. And I know I can't practice. It was so interesting when you said about feeling blind when you look at it 2D. That's how I feel. It's hard because you realize it's literally like driving with one eye. I mean, you could do it if you had to, but you're not seeing everything that you need to see to really be able to do it at your peak performance. And I actually just thought of one other thing, if you don't mind. One question I get all the time, and this be a pretty quick answer, but do you feel that, well, I guess I should preface it with, I felt like once I had some images read in the beginning and got really proficient looking at CBCTs, I didn't feel I needed to send every image out always. I honestly felt very comfortable. I mean, I've looked at tens of thousands of them, understanding what to see. And when I saw something I didn't, I sent it. I sent it to normal maxillofacial radiologist to have it read. Are you comfortable with that approach once people are appropriately trained to be able to look at their own scans and be able to interpret them? Or do you feel people need to send them always and forever?
I mean, there aren't enough radiologists out there to read every single cone beam CT that's generated here in the U.S., and that's why I'm really focusing my efforts in teaching. So here's what I'm going to say. If anyone here would like to take that approach, invest a lot of your time and education dollars in the knowledge of anatomy. Okay, because
Yes,
the
agreed.
interpretation of radiographic imaging is 90% anatomy. 90% of the game here is to figure out if something is normal or abnormal.
Yes.
Of course, there's more to it, but I'm just like, but for someone who is not a radiologist, who's looking at their own scans, if you know what normal is, then you'll be able to pick out abnormal. So thus, it's going to take a lot of time to establish that. It's not it looks okay, because remember, once again, your eyes are only going to see what your mind knows. Right. So you may be looking at the scan and there's something in the temporal bone. And if you don't understand temporal bone anatomy or the skull base or whatever, or you don't understand what a variation in anatomy, a very slight variation in anatomy may mean at the level of, I don't know, the jugular bulb or something like that, then it's not going to mean anything to you.
Yep.
Okay.
Yep.
So broadening your knowledge base, not just doing your continuing education in your specialty, but also in others, because that's another important thing when it comes to interpretation. Not just the specialty of orthodontics, for example, but also do it in perio, do it in surgery, do it, and I personally go out into the world of ENT and chiropractic and physical therapy and osteopathy, all these different things that can offer me more information about this craniofacial complex, in addition to, of course, dental specialties, right?
Yeah. I picked the brains of, when I was going on this journey and started with the CBCT, I started asking my allergist and the ENT that I worked with on the cleft craniofacial team, my ENT, my allergist I knew well personally. I started asking them to take me through some scans and talk me through it, talk me through the anatomy as they see it, to help me. And that helped me a lot too, to be able to start to understand what the medical professionals are seeing in those areas too, to understand the normal versus the abnormal. So that's a great point.
It's not just going to be a quick glance. This procedure, because this is a dental procedure, it's a specialty procedure, just like extraction and implant placement and all that stuff. This will take you at least an hour per patient. Okay. And if you don't want to spend the time doing that, you can send it off to somebody else to read it for you. That's basically another way to look at it,
Yep.
To document, not just to read it, but also to document it.
Have a document, sure. Yep. And then you also have to, I'd add, communicate it to the parent and or patient, because you have to responsibility to let them know your findings as well on those images. So, which I guess gets back to wrap it up to why a lot of people may not want to be doing it. So.
Yeah, I mean, it may be, and I know of many dentists who've done exactly what you're doing, and then they're like, I don't have time. I'd rather be doing something that is going to actually make me money.
Yep, sure,
So they send it off to somebody else.
Dollars,
So they send them off to someone else just for that time, for that convenience,
Sure. Oh, fair. Well, thank you so much, Dr. Dania Tamimi. This has just been awesome. The time flew by talking to you about this. I could geek out on it all day, but to respect your time and the audience's time, we'll wind it up. But it was just great. How can people find you? I'm going to put a link to your book if they want to go through any coaching with you, or they want to reach out to you, have questions on things, social media, whatever you want. Please let us know how we can find you.
I have a website that basically it tells you everything that I do. It's mostly education, so I'm really very involved in education right now. Although I do have a private practice in reading imaging, MRIs, CBCT, and others, the majority of what I do is helping people understand how to read their imaging and how to find the why. Okay. So my website is inspire-imaging.com. Okay. And you'll find my bio, and you'll find all the stuff that I've been involved in, my YouTube, my channel, and my other social media handles and all that stuff over there. So inspire-imaging.com. That's, I think, the best way to do that.
Yeah, I'll put a link to that as well. And thank you so much. This has really been great. It's been an absolute pleasure.
All right. Take care of yourself.
All right.
Okay.
You too.
Bye.
Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.